Good morning. We will have a case discussion today. It's a short case discussion. Will be presented by Dr. Onkar Nath, who is a second year PGT at MR Bangur Hospital. Professor Sanjay Mohan Bhattacharya, who is the professor head of surgery at Vivekananda Institute of Medical Sciences, and RKM Shivapratishthan will take us through this class. And at the end also we'll have a discussion on operative steps. With the short case, we'll discuss the operative steps also. So Dr. Onkar, you can share your screen.
Good morning, sir, seniors, and my dear colleagues. I am Dr. Onkar Nath, second year DNB PGT at MR Bangur Hospital. Today, my topic is case presentation on undescended. 10-month baby resident of Jadavpur brought by his mother with chief complaint of absence of left testicle in the scrotum birth. History of present illness. Mother noticed single testis in the scrotum with empty left hemiscrotum since birth. There is no history of any swelling in inguinal canal, right iliac fossa, or loin. There is no history of any swelling in thigh, root of penis, or perineum. There is no history of any swelling in the groin and no bulging while cupping or straining. No history of trauma. Antenatal history. Mother was on regular antenatal follow-up. There is no history of maternal or alcohol intake or steroid intake. No history of maternal diabetes or preeclampsia. Perinatal history. This was the second baby. Baby delivered term baby was delivered by lower cesarean section with birth weight of 2.4 kg, which was exclusively breastfed for 6 months. First baby was also delivered on term by a lower section cesarean section with birth weight of 2.9 kg. Past history. There is no history of any surgery in the past. Family history. There is no history of similar illness in the family member. Immunization. Baby is immunized up to date as per schedule. Treatment history. Patient has not taken any treatment or received any intervention prior to this for the current illness. Summary. 10-month baby brought by his mother with chief complaint of absence of left testicle in the scrotum since birth. There is no history of any swelling over inguinal region, thigh, or root of penis. There is no bulge on crying or straining. Antenatal history is not significant. There was uncomplicated delivery of the baby by lower section cesarean section with birth weight of 2.4 kg, and there is no significant family history. Coming to general examination, child is examined after taking informed consent from his mother in a well-lit room and proper exposure. After proper exposure, child is conscious, alert, average build. There is no pallor, icterus, sinuses, clubbing, generalized lymphadenopathy, or edema. Vitals: heart rate is 110 beats per minute, regular in right radial artery. Respiratory rate is 26 per minute. Blood pressure is 90 by 60 millimeter of mercury in right arm in supine position, and temperature is 98.3 degree Fahrenheit. Anthropometry: weight is 8 kg, height is 68 centimeter, and mid-arm circumference is 12 centimeter. Now coming to the inguinoscrotal examination. On inspection of the left-sided inguinoscrotal region, there is poorly developed and empty left hemiscrotum, decreased rugosity of left hemiscrotum, no any inguinal bulge or mass, and there is no any inguinal bulge on crying. Right side scrotum is well developed with testis within. Penis appears to be normal and hernial orifice is normal. On palpation of the left side of the scrotum, local temperature is normal, no tenderness is noted, empty left hemiscrotum, and firm nodular mobile swelling of about 1 centimeter into 0.5 centimeter, palpable just outside the external ring. And in the right side of the scrotum, 2 centimeter into 1 centimeter testis is noted at the base of scrotum. Penis is normal, with external urethral meatus at the tip. On systemic examination, on gastrointestinal system, abdomen is soft, non-tender, no organomegaly, and no palpable mass. Respiratory system, bilateral air entry is present. Cardiovascular system examination, S1, S2 heart, there is no murmur, and CNS examination, child is alert and active. Summary. 10-month baby brought by his mother with chief complaint of absence of left testicle in the scrotum since birth. There is no history of any swelling along the path of descent of testis or along the ectopic sides. There is no history of inguinal bulge on crying or straining. Antenatal history was not significant. There was uncomplicated delivery of baby by lower section cesarean section on term with birth weight of 2.4 kg. There is no significant family history. On examination, general examination is normal. Left hemiscrotum was empty. Firm nodular mobile swelling of approx 1 cm into 0.5 cm, palpable just outside the external inguinal ring. Right side of the scrotum and testis is normal. Penis is normal and systemic examination is normal. My provisional diagnosis, 10-month baby having empty left hemiscrotum since birth is most probably a case of undescended testis.
Thank you. Nicely presented. So can you start from the history from the first slide, please? Yeah. So the 10-month baby residing at Jadavpur, brought by his mother, and the chief complaint is absence of the left testis in the scrotum since birth. What is the significance of term the since birth? Is there any significance? Or if patient doesn't say, or the patient mother doesn't say anything since birth, so should we ask, or should you ask her whether it is present immediate after childbirth?
There is history of absence of testicles since birth. So we will think of the congenital anomaly, like undescended testis or ectopic testis.
Okay, why I am talking about occasionally the patient or the mother can see that the testis is in the scrotum, but after few days or the few months, it can be drawn up. Okay.
Yes.
So that's why it is very important whether during the birth or since birth, it is the testis is descended or it is undescended. Okay.
Yes.
And occasionally it can happen also. The testis is not descended at birth, but after few months it has come. So there is a significance. Okay. So second slide, please.
And second is when the mother says that it was in the scrotum and then gone up. What is that condition?
So retractile. It could be retractile.
It could be retractile.
Yes, retractile testis.
So,
and which is common in which age group? Retractile testis we can see in more common into up to the 6 to 9 months of age. After that, the cremasteric reflex comes down. Okay. Okay. And you have said the swelling in the inguinal. Why you have asked that there is no other swelling in the perineum, penis, and in the thigh? Why
So
you have taken the history?
So this is the site of ectopic site, sir. Where
Ectopic site. Okay.
Where testis could be present.
Okay. So what is the difference between an ectopic testis and an undescended testis?
Undescended testis is present. Testis could be present along the path of descent of the scrotum, along the path of descent of the testis. While ectopic testis, in ectopic testis is present beyond the path of descent of testis. It is not along the path.
Yes. Okay. Thank you. You have
crossed internal.
Yes.
Internal ring.
External ring also.
External ring, but deviated after that.
Yes. After that. So you have taken, there is no history of the swelling in the groin or no bulging while cuffing or the straining.
Yes.
And what for?
Yes, sir, that could be associated inguinal hernia.
Yes. Whether the patient that is undescended testis associates with an hernia, so you have taken that history. Okay. No
Yes.
history of trauma? Yes, fine. Next slide. Antenatal history. We have taken the antenatal history. Smoking. So how come the smoking is related to undescended testes or alcohol intake? And maternal diabetes and the preeclampsia.
Sir, all these conditions increases the risk of congenital anomalies.
Okay,
Smoking,
so
alcohol intake, diabetes, maternal
actually
diabetes.
these are the predisposing factors. It has been shown that the patient, that is mother, those who are taking the alcohol regularly during the pregnancy, so and those who are taking the their smoker, they have the possibility. So these are the predisposing factors. Okay, and along with the preeclampsia occasionally produce the preterm delivery. Okay, that's why if the preterm delivery is possibility, though it is not the undescended preeclampsia, that is pre-term delivery, the possibility of undescended testis is there. But one thing we should have taken the history, whether there is any mumps, measles, or that is the viral infection during the pregnancy. Okay,
Yes.
so we should take that history as well.
Yes.
Next slide, please. Perinatal history. Yes, second child. Okay, so what history you have taken for the first child? Because in the few family, you can see the first child may have the undescended testis. So the possibility of undescended testis in the second child is also there. So there is an importance of the family history, whether the patient is having any family history of undescended testis. And birth weight, as because we know that why the birth weight we are talking about?
Yes, sir.
Birth
weight.
Okay.
Sir, low birth weight. Low birth
Yes.
weight is associated with late descent of the testis.
Yes, very good, very good, very good. Next slide, please. Yes, what sorts of surgery can predispose to the undescended testis?
Sir, inguinal surgery, sir.
So inguinal surgery can produce an undescended testis. So it is what sorts of undescended testis? Is it a primary or secondary?
Secondary.
Secondary. So
Yes.
any operation in the inguinal region can produce. Is there any other operation you should take?
Okay.
Suppose the patient has come to you at the age of 1 year. Okay.
Yes.
You want to take any other history, past history of surgery?
Orchidopexy.
No. History, occasionally it can happen. The myelomeningocele, those who are having the myelomeningocele in the lumbar region, as because you know the genitofemoral nerve is L1 and L2. So in that case, occasionally, in case of the myelomeningocele, patient can have the undescended testis. Okay,
Yes.
as because why? What is the relationship of the myelomeningocele in the lumbar region and the undescended testis? Have you any idea?
No, sir.
No. As because you know the calcitonin gene-like factor, that is the these are the peptides which is secreted from the genitofemoral nerve, is one of the causes of descent of the testis from the inguinal canal to the scrotum. So this descent will be deficient if the genitofemoral nerve involvement is there or it is not matured. Okay, so that's why in myelomeningocele, when it is involved, the L1 and L2 nerve, so there is the possibility of undescended testis. Okay, thank you. Next. The family history we have discussed. Occasionally it can happen. The family history of undescended testis in the first child may have the undescended testes as well in the second child as well. Okay, and besides the congenital anomalies, what are the congenital associated anomalies you should think of along with the undescended testes?
Klinefelter syndrome, Crohn Bailey syndrome,
Yes.
meningomyelocele, trisomy 13, 18.
Okay. Thank you. Next. So your diagnosis is now.
Diagnosis.
Yes.
Come to diagnosis.
Last time.
10-month baby having empty left hemiscrotum since birth is most probably a case of undescended testis.
But in
Undescended.
examination, you have described a swelling in the groin
Yes.
close to the cervical ring.
Yes.
So
So
what
you have
is
to specify a little more. Under testis, when you give a diagnosis, in two groups. Is it either a palpable testis in the
Can
line
you
of descent
classify
or
the
ectopic size, or impalpable testis? What is
Can
this?
you classify the
Palpable.
undescended testis?
Yeah.
Can
Yes.
you classify the undescended testis?
Yes, sir. Undescended testis could be transabdominal, canalicular, and intracanalicular and extracanalicular.
That's why sir was asking, as because you have on examination, you have seen it is after the superficial, that is superficial to the superficial inguinal ring. So it is not canalicular, it is outside the, so extracanalicular. That's why you
Extracanalicular.
should specify that point.
Yes.
Okay.
Yes.
Okay. So, okay. So in this case, so if suppose it is like that, have you heard the few terminologies? What is peeping testis?
Yes, sir. Which testis, sir?
Sleeping.
Peeping.
Peeping. Yes, sir. Testis was in testis. Testis is testis present at the testis was previously present at the base of the scrotum, but after but it ascends up due to a cremastic reflex or in that.
No, actually, what is there? Peep in. Peep in means whenever the testis is not descended, it is in the either canal, that is near the deep inguinal ring. Occasionally, it will go above. Above means it will be within the abdomen. Okay. Suppose this is the deep ring. So if it goes into the abdomen and occasionally due to the coughing and straining, it comes into the canal, this is known as the peeping testis. Okay. It is near the deep ring. Okay. This is known the peeping testis.
Peeping.
Okay, the few terminologies are there. So you know the peeping testis is there, vanishing testis is there, or testicular regression syndrome. Have you heard the name of vanishing testis or testicular
Yes.
regression syndrome?
Yes. Yes, sir.
What is that?
Testis is present during the developmental period, but due to testicular, but due to vascular injury, it is not present. Testis is not
Undergone
present.
atrophy.
It is atrophy.
Testis got
Okay, it is atrophy. Okay, fine. So you have seen you have felt a testis which is 1 centimeter in size. What is the size of the testis? You said
Yes, sir.
Size of the testis.
size of the testis.
Normal.
Normal, no? Here, in your
Yes.
case,
You said 1 by 5.5
Yes, sir.
centimeter. In a 10
Yeah.
months old child, it can be 1 to 1.5 centimeter is the acceptable
Yeah.
normal testis.
so it is more or less normal testis. Okay. So for what investigation? Suppose it is not there in the neither in the canal, so you can't palpate it. So what are the investigation of the choice to check whether it is an undescended testis or it is an ectopic testis, or suppose it is an intra-abdominal testis, that is undescended testis within the abdomen or undescended testis within the canal. What are the investigation? You didn't palpate it.
If testis is not palpable, then we will go for diagnostic laparoscopy. sir.
No, wait.
Uh,
Don't jump to radial laparoscopy. Ultrasound is always an extension of clinical examination.
clinical extension, yes.
You can miss a inguinal testis on palpation, but
Why?
ultrasound can pick up. So you don't
That-
skip an ultrasonography. Ultrasonography is not reliable for a intra-abdominal testis.
Yes.
Okay, so keep in mind there are two scenarios. One is a undescended testis, ill-developed scrotum, and testis not palpable. That is impalpable testis. That is one scenario. Second scenario is you can palpate the testis commonly in the inguinal canal or like this near the cervical inguinal ring. So approach
we will
is
go for
a little
ultrasound.
different. But when the question is how will you proceed, the first answer should be I will do an ultrasound examination. Although ultrasound is not 100% reliable for diagnosis, but you palpate something. That has to be confirmed. What is that? And even in impalpable testis also, you should do ultrasound to corroborate your clinical examination.
Finding. Yeah.
So ultrasound is must. Okay, ultrasound. Ultrasound done. Ultrasound does not reveal any testicular-like structure in the path of descent, nor in the ectopic sites. So that is the scenario now. Is a impalpable testis corroborated by clinical examination ultrasound. And here in this patient, we have a situation that testis is there in the inguinal canal and ultrasound is corroborated. Now remain to the first scenario. Ultrasound and clinically testis is not palpable. We have looked at the ectopic sites also.
Yes.
What is the next approach?
Then we will go for diagnostic laparoscopy.
Before that, you should do some investigation to assess patient fitness for
Assess the
decision.
fitness for surgery.
So this is the situation that many people will say CT, MRI, but CT, MRI is not a relevant mission to pick up this small swelling in the abdominal area or in the inguinal canal area. So CT, MRI it should not be said in the examination. The next approach should be doing a diagnostic laparoscopy after proper preparation of the patient.
What you will see in the diagnostic laparoscopy? What we should see?
Yes, sir. If on diagnostic laparoscopy, blind ending vessel is present, then it means their testis is atrophied. Then we have,
Go methodically.
No. Methodically.
First
What
is you look at the deep ring.
See.
yes,
You look at the deep ring. What is normal?
in normally testicular vessels
Yes.
seems to be coming
So
out. from the
in a normal situation, you will find there is no hernia in the deep ring site, number one. Number two, you can see the testicular vessel and the vas, which is pointing at the deep ring. That means that the point is, if you can find the testicular vessel and the vas up to the deep ring, that means that testis has gone beyond the deep ring. It is not intra-abdominal. That is one, normal. And next, what you said is?
Testicular vessel seems to be coming out from the deep rings.
Coming out. That is normal.
Yes, that is
Normal is described.
yes.
What abnormality you can see?
Abnormalities.
You see no testicular vessels.
Yes.
You see no vas-like structure
Yes.
on one side. That means that side is not developed.
Yes.
That side is not
So,
developed. Or what you can see is, you can see a blind ending vas.
Yes.
Just a nodule at the tip. That can be either a atopic testis or a anorchia,
Yes.
not agenesis.
Yes.
Or
So
now you can see a testis-like structure either close to the deep ring or in the iliac fossa. You can see most of the time the testis whether goes to the deep ring. You can see testis-like structure there. So what Dr. Bhattacharya asked is what you can see in diagnostic laparoscopy. So that can show, yeah.
So first you should see whether the deep ring is closed or not. First thing, that is whether it associates with an hernia, that is processes vaginalis was not closed there. Okay, this is number one. Number two, what you have said, we should see the vessel and the vas. Okay, see if we can see the vessel and vas, and what next? We shall have to check whether the blind ending vas or the vessel is absent. So in that case, if the vessel is absent, impression is absent, so then you should think of on the blind ending vas, then you should think of probably it is not there within the canal. So in that case, we can classify it whether it is an intra-abdominal testis or intracanalicular testis. So testicular size, if you see what we said, one lump is seen near the deep ring, then it is okay. It is peeping testis. If you don't see anything, no vas, no artery, then you should check whether there is any swelling in the retroperitoneum or what sir said, it is in the right iliac fossa. Okay, so you should check these three things. And then how will proceed? So you have the 3 or 4 scenario. How you will proceed now?
If blind ending vessel is seen, means testis is atrophied, so nothing to do. If on inguinal, if on diagnostic lab vessels seem to be coming out from the inguinal ring, deep inguinal ring, then we will go for inguinal exploration and orchidopexy. And
you find the testis close to the deep ring, so diagnosis is made. What you will do next?
Three scenarios is there.
Yeah.
orchidopexy,
What orchidopexy?
one stage orchidopexy, sir.
That means while doing the diagnostic laparoscopy, you can do a therapeutic maneuver also. That means if you are finding the testis for deep ring, you can mobilize the testis, the vas and the testicular vessels
On the same sitting.
laparoscopically.
Laparoscopic, yes.
And then you bring the testis out
into the inguinal canal.
In the inguinal canal and the scrotum and do orchidopexy. That is one. So point is, laparoscopically is one for diagnosis, and you find the testis in the deep ring on the iliac fossa region, you can mobilize the testis laparoscopically. While doing laparoscopy, how will you be clear that yes, you have done an adequate mobilization? These testis are brought down to the scrotum. What is the maneuver you do?
For mobilization, sir.
You have done the mobilization. At what point you will feel that yes, sufficient mobilization has been done, and now you can make incision the scrotum and take a first step into the deep ring area and bring it down. What is that? The point is, if you can take the testis, mobilize testis to the opposite deep
opposite ring. Side, opposite.
That indicates a adequate mobilization. So for mobilization, what you do? You first divide the gubernaculum. While doing the mobilization, first divide the gubernaculum, which is coming to the lower pole of the testis, and then mobilize the vas and the testicular vessel from the reticulum. So this is the basic steps of testicular mobilization. You hold the gubernaculum, divide it. It comes from the lower pole of the testis, and then mobilize the vas and the testicular vessels. And now take the testis to the opposite deep ring. If it comes easily to the opposite deep ring, that means it's mobilized well. So laparoscopy is both diagnostic and you can do therapeutic maneuver.
Suppose you have seen it can't be mobilized more than 2 centimeter, or you can't mobilize this completely. What step you can have next?
Sir,
adequate mobilization is not possible on the first sitting. Yes. What are the options?
So we will divide the testicular vessels.
So you mean you will do a Fowler-Stephen procedure?
Yes, sir.
So one option is doing a Fowler-Stephen procedure. That
Any other
procedure
option?
is what?
Sir, in Fowler-Stephen procedure is a 2-stage procedure. In which first step we will go for testicular vessel ligation and
Fowler-Stephen procedure. Don't confuse. Fowler-Stephen procedure can be done as a 1-stage or 2-stage procedure. If you are doing as a 1-stage procedure, you divide the testicular vessels, mobilize the testis, mobilize the vas deferens area, and bring it down to the scrotum in same sitting. But the problem is
before doing
there
that,
is more than 50% chance of atrophy. If you are doing a single-stage Fowler-Stephen procedure, there is more than 50% chance of testicular atrophy. But if you have decided that you will do a 2-stage Fowler-Stephen procedure, you go in, find the testis there, clip the testicular vessels. Don't mobilize. You allow the collaterals to develop from the cremasteric vessels and artery to the vas. So just clip and leave it there. Don't mobilize. And then after 3 to 6 months, you go in again and divide the artery and mobilize. So this is 2-stage Fowler-Stephen procedure. The problem with the Fowler-Stephen procedure is it is actually the higher incidence of testicular atrophy. That means the vascular supply is not adequate to be maintained to the artery to the vas or cremasteric vessels. So one option is Fowler-Stephen. Second option?
Similar procedures.
What is that?
Orchidopexy by microvascular anastomosis. In this case, testicular.
What is the anastomosis?
So in this case, testicular vessels is divided, and scrotum and testis is brought down into the scrotum, and testicular vessel is anastomosed with inferior epigastric vessels.
Yes. So this is a microvascular procedure where you can divide the testicular vessel, bring the testis down, and anastomose this to the inferior vessels, artery and the vein. And next option is
other option is in one step we brought down the testis and spermatic cord up to the inguinal ring.
yes. So
After-
this is two-stage procedure.
Yes.
The third option will be a two-stage procedure where you mobilize the testis as far as possible, and maybe if you keep it and bring it to the mid-inguinal canal or whatever is comfortable position. So bring the testis as much as possible to the site of the inguinal canal and mark the area,
Yes.
and do the re-exploration after about 6
After
months. So this is two-stage orchidopexy. And last option is, if you find the testis atrophic, cannot be mobilized, there is option for doing orchidectomy, provided the opposite testis well descended. So these are the options why the adequate mobilization is not possible. Okay.
Okay, suppose you have seen the testis is atrophic, so you have taken out the testis. What do you want to do with the testicular specimen?
We will go for biopsy, sir. Testicular biopsy, sir.
We'll send the specimen for histopathology.
Yes.
Don't say biopsy, for histopathology.
Yes.
Okay. So suppose you have seen, you have mobilized all the testes in the inguinal canal. Okay. So you have seen in the laparoscopy, your diagnostic laparoscopy, vessel is there, it has crossed, and the vas is there, it is there, everything is there, and the testis is within the canal. Okay. So you said you can do the Fowler-Stephen technique, and okay, we'll come in the operative surgery. Okay, what do you want to do in your case?
You find there is a testis palpable close to the cervical ring. How will you approach this patient?
Your case, yes.
Sir, first we will do, sir, ultrasound, sir.
Yes. So
Ultrasound.
ultrasound. Confirm that this
Confirm.
is a testis.
Testis.
You can see the testicular structure, you can see the vascular supply. So assess. Yes, that corroborates it's likely testicular swelling and it's close to the cervical ring.
After that, we prepare the patient for surgery.
Any
Do
form of waiting is
Sir,
possible?
up to 6
you
months.
said
we
you
will-
said no,
You
patient is
said
10
10
months.
months.
Yes, sir,
You
10
have
months.
said it
Patient
is 10 months.
Patient is 2.4 kg weight.
Yes.
So
So
if
you
you have
said-
a swelling of this dimension, you can still wait for few more months. It is described
So
that
rather,
premature
we
baby
can
can be up
say
to 1 year.
timing of operation. Rather, we can ask you the timing of operation. As
Yes.
because you said it is 2.4 kg or 10 months. So what is the ideal time of operation in an undescended testis?
Normally 6 months to 12 months. Sir.
Yeah.
Okay.
In
Normally-
premature baby,
In
in
pre-
premature
up to-
baby, it can descend. Usually,
Descend
the
up to
testis
1
descends to the scrotum by
3 months.
3 months, at best by 9 months.
Yes.
But in premature baby, it can descend up to 1 year.
1 year.
So there is a point of waiting for about little more period, because once you find the testis is gone beyond the cervical ring and palpable, this can descend. And here is a situation where one can consider for giving some endocrine therapy also. When the testis is at this level, some endocrine therapy may help in proper descent. But
Yes.
still there is a point of waiting in
Still-
this.
Yes. Okay, so you have done all investigations and you have seen that everything is fine, testis is normal, more or less normal, even if it is in the normal size. So what do you want to do? In this
Open-
case, your case, you will do
Open orchidopexy.
orchidopexy, open orchidopexy.
Yes.
Okay. Okay. Now, how you want to do open orchidopexy? As because the
operative step, but before that, some point on testicular undescended discussion like development
Yeah.
of testis, some descent.
Okay. Okay.
Uh,
Okay. Okay.
last
So
15 minutes of the
development of
operations.
testis. Okay. development of testis. Have you any idea
Yes.
where it develops, how it
Yes.
descends?
Yes. Testis develop in the retroperitoneum by genital ridge in the 4th to 6th month, 4th to 6th week of gestational period.
Okay.
And then it starts to descend.
What is that? What is that? You said genital archeum. What is that?
Genital ridge. Yes.
What is that ridge? Is it thickening of mesoderm?
Yes.
Is a thickening of mesoderm medial to the mesonephros. This is a thickening of the mesoderm in the retroperitoneum, medial to mesonephros. That
Yes.
is genital ridge.
Intermedial to the mesonephros.
Okay.
Okay.
So in this testis, when it starts developing, the derivative are not all from the genital ridge. If you talk of the germinal cells, if you talk of the first difference, these are not all developing from the genital ridge. So now tell me where from the germinal cells of the testis comes from.
Okay.
They migrate from yolk sac. These are primordial cells from the yolk sac, number one. And testis has got a duct. Testis has got a duct, that is first difference.
From
the
where
from mesonephric duct.
Yes. What happens to mesonephros?
Sir, it mesonephros in 10th week of intrauterine in 10th week of gestational period, mesonephros disappears. Sir.
Yes.
But mesonephric
So if you
duct,
go to the development of kidney, they are all related. The pronephros disappears, the mesonephros disappears, but the mesonephric duct persists. And that mesonephric duct is the first difference. And what happens to metanephros? That is another thickening of mesoderm in the retroperitoneum. Metanephros is? Yes. From metanephros develops the kidney. And metanephric duct is? Metanephric duct is ureter. So keep in mind, these are all related development in the retroperitoneum.
So that's why
mesoderm, which is pronephros, which comes up much earlier, disappears. The thickening of the mesoderm is mesonephros. Mesonephros disappears, but mesonephric duct persists as first difference. Metanephros gives rise to kidney, and the mesonephric duct persists as a ureter. And in the genital ridge, the primordial cells or germ cells are derived from the primitive yolk cell. And this testis is developed by about 8 weeks of intrauterine life. That means differentiation starts by 8 weeks intrauterine life.
So how it differentiates?
Yeah.
Under the influence of?
Survive genes.
Huh?
Survive gene is responsible for the testicular differentiation.
Okay. S or Y genes.
One is gene.
Fine.
And subsequent.
Another?
Differentiation androgen cell.
Androgen.
And endocrine infants. Endocrine infants. You see, even when the gonad starts developing, it is not differentiated gonad. It's a undifferentiated gonad. And with influence of one is genetic background, your X or Y chromosome, and second is endocrine influences. So if you have the androgens coming up, that will lead to development of testis. And then there is another important substance that comes up. That is not a MIS, Mullerian inhibiting substance. That is an important factor which suppresses the Mullerian duct and the Mullerian derivatives. Because sometimes you find some hermaphrodite. In hermaphrodite individuals, you find the testis. Same time you find the uterus and the adnexa.
So this
that
is
described as MIS incendiary syndrome, Mullerian inhibiting incendiary syndrome. That means here the Mullerian structures are not inhibited. So this development testis is dependent on the chromosomal influence and endocrine influence.
Actually, these are the structure, two things we should think of. The one is Leydig cell and another is the Sertoli cell. Okay. Yeah. So from the Leydig cell, what is coming out? So
testosterone.
Yes.
Testosterone. And Sertoli cell secretes
Mullerian inhibiting substance.
Yeah.
Yes. So these are the two things we must know, as because it is attached to the intermedial to the kidney. One is cranial suspensory ligament. That cranial suspensory ligament is disappeared under the influence of the androgen. That's why we must think of the hypothalamic pituitary adrenal axis or gonadal axis. If it is okay, then only this will develop. That's why occasionally in the microcephaly, you can see that the patient is having the undescended testis. So why that axis is not appropriate in that group of the patient? Okay.
So what are the
Fine.
factors for descent? One is it's now start differentiating as testis. And what are the factors for descent?
There's
Factors.
hormonal factors and the mechanical factors.
Yes.
In the hormonal factors are androgen.
Before that, what Dr. Watcher says,
Inhibiting
intact pituitary
hypothalamo-pituitary gonadal axis.
Yes. So intact axis and its hormonal influence is important.
Yes.
And
So
from there comes androgen.
Yes.
And the mullerian
inhibiting substance, calcitonin gene-related peptide.
Yeah.
EGF.
So they are the hormonal effect.
Yes.
What is the mechanical effect?
Mechanical sir, increase intra-abdominal pressure due to increased visceral.
And don't ignore the gubernaculum, although it is questioned now. But
pull up the gubernaculum.
Gubernaculum is a thickening of the tissues from the lower part testes, and it was said that it is extending from there up to the scrotum, which pulls the testes down to the scrotum.
Yes.
So mechanical factor and the hormonal factor. What is the chronology of descent from the L1 level up to the scrotum? Chronology.
One thing, Makanda, just before one thing, intra-abdominal pressure, because we are discussing about the intra-abdominal pressure, that's why we should think of whenever there is an gastroschisis, or it can happen, or it can associate with the undescended testes, or the prune belly syndrome patient can have the undescended testes. Why? The development is not there, appropriate intra-abdominal pressure is not there. So that's why it is not descending. So it is another factor we should keep in our mind. Okay? Yes. Give the answer what Makunda asked.
Chronology of testicular descent from L1 up to the scrotum.
Testis develop at the level of L1 in the 4 to 6 week of intrauterine life. After that, in the second month of intrauterine life, it is present in the right iliac fossa, in the lumbar region. In the third month, it is at the right iliac fossa. At the 7th month, it is at deep inguinal ring, and it descends into the inguinal canal in the 7th to 8th month, and reaches superficial inguinal ring at 8th month. Reaches superficial inguinal ring at 8th month, and up to the base of scrotum at 9th month.
Yeah. So that is the usual chronology of testicular descent. Okay. So you said testis can deviate to the ectopic sites. What are the factors for this deviation?
Pull up the gubernaculum has 5 tails. If there is a differential growth of
so these are locute tails.
Yes.
As you talk of ectopic testis, that is dependent on the locute tails. So normal locute tail is a long tail that goes to the scrotum.
Scrotal
the other tails goes where?
The other scrotal tail, pubic tail, femoral tail, superficial inguinal tail.
Yeah. And perineal tail.
Perineal.
So depending on this,
are there.
Yes.
Yeah.
Okay.
So now you said there is a situation called a ectopic testis in the inguinal pouch and undescended testis in the inguinal canal. Got it?
Yes.
One form of ectopic testis is inguinal. That means that goes beyond the superficial ring and then come back to the inguinal region. That is known as superficial inguinal pouch. How you differentiate? How to differentiate an ectopic testis in the inguinal pouch versus a testis in the inguinal canal, which is taken as undescended?
We will go for leg raising test. On leg raising test, abdominal muscles will become taut, and ectopic testis within superficial to the deep inguinal ring, to the superficial inguinal ring will be palpable, while undescended testis, which if it is deep to the deep inguinal link, then it will not be
Due to the external aponeurosis, will become less palpable.
less palpable.
It is
So
difficult
that's
to do
why-
any. Yeah.
It will be prominent, it will be more prominent, it will be less prominent. Okay. So one thing, it will be less prominent, or it will be more prominent. Okay.
You say the testis close to the cervical ring. How do you differentiate between a retractile testis vis-a-vis a undescended testis?
So retractile testis could be manipulated up to the base of the scrotum.
Before that,
So retractile testis.
What about the scrotum?
Scrotum will be normal in case of
Yes.
retractile testis.
So in retractile testis, you find the scrotum is well developed because
developed.
sometimes the testis was in the scrotal sac and then it's
Then-
gone up by chemistry reflex.
Yes.
So if it is a retractile testis, the scrotum will be well developed. You can find the rugosity in the scrotum. And you can manipulate the testis
Up to the
down
base
to
of
the scrotum. In an undescended testis, it's difficult to do the manipulation down, and you find the hemoscrotum is ill-developed. Okay. What are the complications of undescended testis?
So there could be torsion, trauma, and malignancy.
What malignancy?
Sir, most commonly, sir, seminoma.
Seminoma.
There could be choriocarcinoma, teratoma.
Okay. So what else complication?
Mm,
Undescended testis, complication of undescended testis.
yes.
3T,
sir.
3T, trauma, torsion,
Trauma, torsion,
tumor.
dead tumor.
Infection, occasionally epididymitis also. Huh?
Yes, sir.
Testis, and so that's a mnemonic
Testicular atrophy.
testis. Yes.
What
So
are
I
the
think-
factors which hinders testicular descent?
So if there is short vas difference, short testicular vessels.
Yes.
If gubernaculum pull is not sufficient.
And important is adhesions.
Yes, adhesion.
If you have
So
adhesion, there is
the
a vietnam or
retroperitoneal adhesion is the
canal,
main
this
factor.
adhesion can prevent. Okay. And then the hormonal factors which can prevent the descent.
Testicular descent.
Okay. I think we can go for these operative steps.
Yeah.
Uh,
So in your case, suppose it is an undescended testis. So testis is in the near the deep ring. So you have diagnosed it. How you are going to explore the patient?
Describe the steps of orchidopexy.
Orchidopexy done under general anesthesia. After proper dressing and draping, we'll go for inguinal incision, and external oblique aponeurosis is incised and divided. And then we will do herniotomy for if there is associated inguinal hernia, and then we will mobilize testis and the scrotum, and mobilize testis and the spermatic cord, and then we will keep our finger inside the
You need to divide one important structure. Once you-
patent processes within it.
That you have done. You have tackled the hernial sac.
Yes.
And now once you pick up the testis,
Yes, sir.
you find there is something is adhering this to the lower polar testis. Going down. Yes.
Gubernaculum. We will.
The first semester you have to divide the gubernacle and the lower polar testis.
Yes.
And then mobilize the testis,
Yes.
taking its vas and the testicular vessels.
Yes. After that, we will move our finger inside the scrotum through the inguinal incision, and
No. Before that, you shall have to check whether you have mobilized it completely, or this length what you have mobilized,
Adequate mobilization has been done.
it is adequate or not.
Yes.
So suppose you have mobilized it, it is not adequate. So while you have separated the processes vaginalis, so you have separated it, sac is closed, and then what else you can do to increase the length of that vas?
Sir, we can divide inferior epigastric vessels.
No, before that,
Before that, sir, we will go for seeds, dissection of the spermatic covering, and we will dissect all the spermatic covering due to which
And
You
you
know
do
what
a
covering?
little retroperitoneal dissection.
yes, sir.
You close the deep ring, you can design retroperitoneal and
You
mobilize the
should,
vas in the distal vessels.
yeah, the deep ring, you should have to target that area. So whatever the structure strand is there, you shall have to separate it completely. And even then, if you can't mobilize, then whatever you said, so you shall have to do. What are the things you can do?
We will divide inferior epigastric vessels, sir.
Yes.
With,
Only inferior epigastric, or you can do something else?
testicular vessel, we will divide testicular vessels.
No, 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 no,
One by
no,
one.
no, no.
One by
One
one.
by one.
If it's inguinal canal, usually distal vessel division is not required. You can mobilize that. Once the next step is you can divide inferior vessel and do a medial displacement of these
Medial displacement of
structures.
this.
How you can do the medial displacement? Some fascia is there, you shall have to cut that fascia. What is the name of that fascia? Fascia transversal.
Fascia transversal.
Fascia transversal.
Yes.
Yes. You strip the fascia transversalis and displace the cord medially. That gets some more length. Now then you have done an adequate mobilization. You will now describe the fixing the testis to the scrotum. Where do you place? You describe one step and you can describe
Yes.
the alternatives. What do you do next?
After mobilization, we will place our finger in the scrotum through inguinal incision to enlarge the scrotal sac. Then we will make a 2 to 2.5 centimeter incision in the scrotum, and we will make a subdartos pouch. And after that we will mobilize the testis into the subdartos pouch. And
How? That is the trick.
yes,
You made the subdartos pouch. How you will transfer the testis to the subdartos pouch? Have you seen it?
yes, sir. Through inguinal, normally through inguinal incision, sir, we will transfer the testis into.
No, try to understand. You have made a skin incision and you have now mobilized the skin flap, dissecting between the skin and the dartos muscle deeper. So that is what is described subdartos pouch. You have the skin now and dartos deeper. Now it's a septum. How will you bring the testis into the subdartos pouch?
Through skin incision,
Yes.
which we have given
In the scrotum. You pass
and
a
we will
hemostatic
pull-
forceps and
yes,
you are
we will-
stuck with the dartos.
Yes,
You have to make an opening in the dartos.
Yes.
in the
So
So
as you
that-
push the hemostatic forceps, you are pushing the dartos up. So make an incision in the dartos, in the scrotal layers, not only dartos, all the layers of scrotum, and open up the hemostat. Catch the gubernaculum, or put a thread in the lower pole of testis
Testis.
and bring it through the
inguinal.
scrotum into the subdartos pouch. Subdartos pouch is a pouch created between the skin and the dartos
Dartos.
muscle and the other deeper layers of the testis and scrotum. But you have to make an opening. You have to make an opening in the deeper layer. That is the dartos and all the layers of the scrotum. And through this opening, you bring the testis. If the mobilization is good, you can bring the testis easily into the subdartos pouch. If the mobilization is not perfect, it will pull up. So you have to ensure that you have done a good mobilization to place the testis in the subdartos pouch. And if you have done a good mobilization, further fixation of testis in the subdartos pouch is not required. You place the testis, taking care the sinus of the epidermis will be looking laterally. And then just close the skin of the scrotum. And then close the inguinal incision. So that is one way of fixing the testis in the subdartos pouch. How else you can fix the testis in the scrotum? What are the other?
There are other techniques, sir, like lead and gross technique.
What is that?
So in this case, first we enlarge the scrotal opening, sir. Scrotal sac. First we will enlarge the scrotal sac. Then we will mobilize testis and scrotum, and we will make we will stitch testis over the medial over the thigh over a rubber tube. We will anchor testis.
Yes, Dr. What is the question?
No, I don't have. Just tell. So with the rubber band, what you are doing?
We will anchor the testis of our thigh.
Is it?
Over
No,
rubber.
not this thing. Try to understand. You have created space in the scrotal sac and bring the testis down into the scrotal sac. Now you have a wide scrotal neck. The next step is you have to narrow the scrotal neck around the cord. Next is take a stitch at the lower pole of testis. You have two ends of the thread. You don't bring the testis into the thigh. You have two ends of the thread. Bring this thread out through the scrotum.
Through the scrotum.
And fix the thread over a rubber band on the middle side of the thigh. You don't fix the testis to the thigh. You take the bite to the tunic albuginea and the lower pole of the testis and bring these two threads through the scrotum and fix it over a rubber band on the middle side of the thigh.
Because if you want to fix the testis in the thigh, it will be exposed.
Yes.
So it will be with the scrotum.
So that is lateral gas. What is the other technique? Lateral gas is this.
Yes, Ombre-Dance technique, sir.
What is that?
In this case, sir, testis is mobilized into the other opposite side of the scrotum.
How?
By medial septum of the scrotum is.
Yeah. So mobilize the testis well. You make an opening in the median raphe or median septum of the scrotum. Make an opening there. Take the testis to opposite side. That means you make a small opening in the septum and bring the testis to the opposite scrotum. So this is ombre. That is, if you are taking the testis to the opposite scrotum. So the idea is so that it does not slip back to the inguinal canal. So you have to make a small opening in the median septum of the scrotum.
So
what is Kittley-Tourette?
What else?
Kittley-Tourette technique. Testis is mobilized in between the skin and the fasciolata in the medial aspect of the thigh. And
how do you take the testis there? You take the testis through the scrotum. So you mobilize the testis. You see, scrotum is so small. Irregular scrotum. You cannot place the testis in the scrotum itself. So stretch the scrotum. Make an opening in the scrotum. Bring the testis out through the scrotal opening. Make a small incision in the thigh, middle side of the thigh. Place the testis thigh pocket and stitch the scrotal incision with the thigh incision. Now we have the scrotum being sutured to the thigh incision. So after 3 to 6 months, you just take this skin flap and bring the testis into the scrotal sac. So this is Kittley-Tourette. Dr. Maiti, any question on this in the testis? We have a pediatric surgeon. Dr. Maiti.
Am I audible? Actually, there may be
yes. Dr. Maiti,
connectivity problem.
Yes.
Yes. Because there may be connectivity problem on the road. Excellent discussion. I can say what we have discussed with Dr. Professor S.M. Bhattacharya was unique and excellent. And I hope many of the students who have not joined in the class, they will miss something. Excellent class, excellent discussion. And everything have been almost discussed. Only few points I want to mention that there is another condition of ectopia of the testis, that is the crossed ectopia. So the patient may present with undescended testis on one side and testis may not be seen on the side of the where it's complained of. The testis may not be found on that side. Sometimes the ultrasound may miss the testis on the crossed side, because suppose there is undescended testis on the left side and the patient presented with a normal descended testis and a hernia on the right side, then the left testis may be missed, that may be hidden behind the hernia, and ultrasound sonologist may miss that testis. recently, just a few days back, I operated a case of undescended testis on the left side and right sided hernia, inguinal hernia. There was a cross diphtheria on the right side for the left testis. So that is important thing. And another thing is malignancy associated with undescended testis. The operation of orchidopexy for undescended testis can, even in the early age of 1 year, 6 months to 1 year, cannot totally prevent the development of malignancy. The incidence of malignancy still is very high, even in a testis which had been done, treated by orchidopexy. But the advantage is that we can palpate the affected testis malignancy when it is within the scrotum. So that is very important. So incidence of malignancy is maybe lower, but that cannot be avoided by even by orchidopexy. Otherwise, it was very excellent discussion, excellent.
Any last minute question?
Yeah.
2 minutes.
The question is, suppose you have done orchidectomy, so or you have done orchidopexy. In the follow-up, how you should assess? What are the points you should check? Sir was asking what another is the size of the testis, whether there is an atrophy due to the vascular ischemia. What Mahonda has discussed, the 50% or in case of the canalicular testis, 10 to 20% cases of there can be an ischemia of the testis, ultimately there might be an atrophy of the testis. And second thing, if you can't bring the testis to this Fowler's Stephentexic or whatever you have done, or the testis is absent, so psychological problem of the child will be there. So whenever the child will grow, we should keep in our mind, if possible, to bring down the psychological aspect, we should implant an testis on that side after few years, that is 3 to 4 years. So we should implant that one. Okay. So this is my last.
Okay. And now the more important thing is patient counseling. So mother has come with the baby.
Yeah.
So there is a need for surgery, and a lot of people have the belief that no surgery. How will you counsel the mother regarding this condition? Mother, you have given the diagnosis, you have done everything, now you have planned something. How will you counsel the mother regarding the condition and the treatment and the outcome? Just keep on discussing these few points.
We will counsel the mother about the that if a surgery could not be done, then
surgery is the first tell the mother the diagnosis. How do you communicate the diagnosis? And mother might feel that something wrong happened during pregnancy, that's why this has resulted. She might feel that she is at fault. So how do you counsel the mother? First, you get the diagnosis. What is the need for this treatment and the possible requirement for orchidectomy? They're all important. How do you counsel? You see, this is a new field coming up now. Even MBBS students has this part of the discussion. Every point there is a addition saying that is known as ATCOM, Attitude, Ethics and Communication. This is a big thing in MBBS curriculum, and gradually it will come up in the PG course also. So the proper counseling should be, you should tell the mother that this baby having a condition known as undescended testis, that means testis have not gone to the scrotum, and it assure the mother this is not an unusual situation. This happens in number of children during the development, and somehow the testis got arrested in the line of descent, but your baby has the good parties. It has descended to the great extent. It has almost come to the root of the scrotum, and it's likely that we like to wait for another 2 months or 3 months to see that whether this comes to the scrotum or not. If it comes continuously, baby will not require an operation. So this might be reassuring for the mother. So that is one way of explaining that your baby is having a situation which is a congenital defect. This happens in number of child, so that she get assured that yes, nothing has happened that which is very unusual. And we like to wait for about 2 months. Before that, I can ask for an ultrasonography to see the testicular size, how it is it being the normal size or is showing some decrease in size. And then now we have decided for surgery. Then the counseling should be, you see that this is a testis which has not come down the scrotum, and the normal location of the testis should be the scrotum. And the difference between the testis being in the abdomen scrotum is the scrotum is little an area which is well protected, the temperature is lower, and testis has to function for production of sperms for continuation of the reproductive life. In that case, the ideal place for the testis should be in the scrotum, and we need to bring the testis down to the scrotum. If you don't bring it to the scrotum, there might be some problems with this child when he starts growing. It can be having some pain because of trauma. It can undergo some rotation known as torsion. It can damage the testis, or if it is higher up, it can develop a tumor, and then it will be a more life-threatening situation. So he needs some form of surgical treatment. For this, into some investigation. And then mother might ask, is surgery a 100% cure? Then you have to be guarded. As you already described that, orchidopexy does not give immunity to development of tumors. So you should be both optimistic and also you should explain the situation. You are right that it's not 100% guarantee that patient will have any problem subsequently, but once you're bringing the testis down to the scrotum, you can regularly keep a vigil. You can see me and I can have a regular checkup whether he is developing any swelling in this swelling or not. And you can keep a close follow-up for his subsequent use. But again, yes, surgery has some own intrinsic complications. Surgery can cause some bleeding in the apical area. Even after surgery, the testis may not grow. Even after surgery, the testis may shrink. It may undergo atrophy. This can happen. But you should not get scared, but the ideal treatment and the proper treatment should be bringing the testis down to the scrotum, and we plan to do it at the end of 12 months. So these are the new things coming up. Now even in TISA RRC also, they add this part, communication, and then taking a consent, all are important.
So this is to be done before operation. Before operation. This counseling to be done before operation.
And you have to take a consent for orchidectomy also, because you have assessed clinically or by ultrasonography. But on a mind is atrophic. If it's a grossly atrophic testis, there's no point doing an orchidopexy down there. So you have to explain the mother and take a consent that while doing surgery, he might need to do a orchidectomy. And you have to assure the patient that one side testis are developed well and he can carry on with all his activities, sexual life, everything will be possible with one testis. And also he will not be unfit for any medical point of view for any job if you have a therapeutic maneuver of doing orchidectomy and other testis being normal. So that point has to also be counseled. Okay, Dr. Varshaj?
Okay, thank you.
Thank you.
Thank you.
Thank you very much.